I'm going to turn this over now to Dr. Aldridge, my co-chair.
Thank you, Maureen. I can tell you that it's the patients who are doing the work in this organization, and I sort of stand back and say, go ahead, you're doing a good thing. Anyway, it's my pleasure to introduce Dr. Oberg this morning to you. I won't read his bio fully, which is in your book, but just to mention that he is the professor of endocrine oncology at Uppsala, a former chair of that department and a former dean of his medical school. Dr. Oberg has been very active in neuroendocrine tumor caregiving and research. I see he has more than 400 publications to his credit, as well as book chapters and many other activities. He was instrumental in the founding of the European Neuroendocrine Tumor Network, and I'm sure we're going to hear some more about that. So why don't you come up and talk to us, Dr. Oberg?
Good morning, everybody. I'm happy to see that so many have been awake this time of the day. And what I will do during the next 40-45 minutes is to discuss with you the development within this field of neuroendocrine tumors. I have been myself working with these tumors since 1977, so I have some perspectives. This first picture is delineating the old anatomical theater we have in Uppsala called Gustavianum, but this is from 1600. I'm not going to take you back to 1600, just a few years back. I think it's important for you to realize that you're not alone with this disease, that there is a lot of sisters and brothers around here in Canada, because this disease is really increasing in incidence and prevalence. And this is a study we did a couple of, 1 year ago now, and all different subtypes of tumors are actually increasing. We have a mouse here. And what is really striking is that the lung tumors are increasing even more than the gastrointestinal tumors. If we look at the most recent data coming out from the James Yao study in 2008, the incidence now for all neuroendocrine tumors is about 5.25 per 100,000, and the prevalence 35 per 100,000. That means that here in Canada you have around 11,000 people with this disease. It's also important to point out that this disease is, if you look at the gastrointestinal neuroendocrine tumor, they're the second most common gastrointestinal cancer type. It's just after colorectal. So it's far more common than gastric tumors, pancreatic adenocarcinomas, esophageal tumors, and also hepatobiliary cancer. And it's less funded, at least in the US and also in most other countries. So what I will talk with you today is the advances in classification of neuroendocrine tumors, stop mixing apples and pears, that has been going on for long. If you look back just 10 years back to the publications, they are putting together pancreatic tumors with small intestinal neuroendocrine tumors, carcinoids, and so on in different studies. And I'm going to show you that the tumor biology is quite different. Biomarkers, we need more sensitive biomarkers. We heard yesterday from Dr. Ardell that there is ongoing now studies to develop new, more sensitive markers. I'm going to bring up some of our most recent ones. And molecular imaging I was talking about yesterday, so there will be just a brief summary of that. and then I will discuss in more detail the therapeutic landscape. So I think to be able to put this field forward, we had to realize that we had to subclassify all these diseases so we can improve both the diagnosis and treatment of these tumors. And we had to stop mixing apples and pears. I still hear quite often from patients coming from different countries to our center that they are talking about carcinoids, and that is the disease, and it's carcinoid from the pancreas, carcinoid from the duodenum, carcinoid from the large bowel, and so on. And so we had to look into this and see what can we do today in terms of classification. I just show you, you heard Dr. Essat last night talking about genetics in neuroendocrine tumors. And this picture, which is looking like a mat, is just indicating a microarray of normal EC cells. These EC cells are located in the intestine, and they regulate the intestinal function in terms of secretion, motility, and so on. And compared to the classical midgut carcinoid, which is the offspring of these cells. And you can see, if you look at the green and the red color means that genes are upregulated, green color that they are downregulated. And this is a study we did 1 year ago, and you can clearly see that there is a difference between the normal tissue. It's not so easy to handle this mouse. It's slippery on the table. I think I'll continue with the laser pointer. If you look at the normal tissue, it's quite different in the expression of genes compared to the tumor that is developing from these kind of cells. So, of course, we have to learn more about it. It's not easy, but we have started to move into this field. Another thing which is quite intriguing is that the genetic background for GI carcinoid or classical midgut carcinoid and pancreatic neuroendocrine tumors is also different. So you must keep that in mind. And this is a study from Boston, from a group around Matthew Kulke. And again, red colors means that their genes are upregulated, and blue color that they are downregulated. And it's quite obvious from this that there is a clear difference in gene expression between the carcinoid and pancreatic tumors. So therefore it's clear unfair to put these together into clinical studies to treat them in the same way in the future. We heard yesterday about the WHO classification. I must say that it was developed in 2000 and it was redefined in 2004. And from the very beginning, no one took any notice of this classification because they thought it was very difficult to use it. But today it has come more and more in the clinical practice, at least in Europe, and it's also supported by ENETS. And if we look at WHO1, well-differentiated endocrine tumor, proliferation less than 2%, and WHO2, PI, proliferation index between 2 and 20%, and WHO3, which are the poorly differentiated endocrine carcinoma, the high-grade tumors. Is that of value in the clinical practice? First, I just want to point out the problem with the first classification that came out and was also discussed yesterday morning, and that was this group, uncertain behavior. These tumors had a size about 2 centimeters and a proliferation about 2%. And people didn't know where should they put them into this classification system, but today it's quite clear that they should belong to this group, well-differentiated endocrine carcinoma, this group of patients. So we looked into 324 patients with pancreatic endocrine tumors, and we looked at the WHO classification, and you can see there is a clear difference in survival between WHO 1, 2, and 3. So of course, this type of classification has some clinical value. Another thing that was brought up also yesterday was the Ki-67, this proliferation marker. I must say that I don't agree with Dr. Essat, who said that this was crap and the past, because it's only the last 5 years it has come into clinical use. So I just give you an example how we use it, and you can then make your own opinion. But looking at these two specimens, they are coming from patients with the same diagnosis. Both of them were said to have classical midgut carcinoid tumors, and they came at the same time to our unit. They had the same level of 5-HIA, they had the same level of chromogranin A, and they have the same amount of liver metastases, metastatic disease. The guy in the upper panel showed a few dividing cells. These are the brown spots, you see, that they are stained with this MIB1 antibody. And the other guy down here, he had a lot of dividing cells. The one up here is still living 25 years later, and this guy died after 7 years. So of course, this is has an implication for how we should treat these patients in the future. They should not have the same treatment, of course. And I must say that I agree with Dr. Essat that it's not the ideal thing we had today, the Ki-67, because you have some problems. You heard from Dr. Odoris about the salami sausage and cutting. Of course, you have areas within the tumor where you have uneven distribution. But if you do a global estimate first of the proliferating cells and then look at the hot spots, because if you have hot spots in the tumor, these are the dangerous cells that you have to take care of. So if you are using this, I think it's guiding you in terms of management of your patient. Just to look in the same material, 324 patients with pancreatic tumors, is a clear difference in survival between Ki-67 less than 2% and Ki-67 above 2%. So it has implication again for the management of the patient. To further improve this classification, which was based on 2000-2004, ENETS have decided to make a TNM classification. And TNM classification is quite common for all other types of cancers. And just to give you one example, you can read about all the different subtypes of neuroendocrine tumors in our journal Neuroendocrinology, where all the different TNM classifications of the different subtypes are listed. Just to give you an example about a pancreatic TNM classification, and you can see that T1 tumors less than 2 centimeter, T2 between 2 and 4 centimeter, and T3 tumors above 4 centimeter, and then T3 tumors and T4 tumors invading other organs. And if you look at this, can it be used in the clinic? Again, there is a study coming from Italy looking at 155 cases, and it's quite clear that you have a difference in survival between T1 and T2, T3, and T4 patients. So it seems to work quite well. To further improve our classification, we also looked into a grading system. And this grading system is different from the American grading system, which came out a couple of years ago. And you can see the mitotic count and the Ki67 index for grade 1, grade 2, and grade 3 tumors. And can that also be used in the clinic? We tested it in a group from Berlin in 202 cases with 4 gut tumors, gastric, duodenal, and pancreatic tumors. And you see a significant difference between G1, G2, and G3 tumors. So what we are now doing, and hopefully we'll have some data until next ENETS meeting in Berlin in March, is to collect all the data from the different centers in Europe using this classification system and see if it's still working well in the clinic, or if we have to modify it in some way to be even better to classify our tumors. So this is one of my take-home messages for you in Canada. You must discuss with your doctor about the classification of your tumor. So biomarkers. We heard yesterday about that we have rather good biomarkers in terms of chromogranin A and so forth, but looking into the crystal ball, I think we need some more sensitive markers for early diagnosis and follow-up. You heard about chromogranin A. We have other general markers. I will not go through them, and also specific markers related to the clinical syndrome. The chromogranin family is growing, and it's quite big at the moment. Chromogranin A and chromogranin B are routine analysis in our lab at the moment. Secretogranin 6 or NESP55, the last on my slide, is mainly used by our pathologist. You can see that both chromogranin A and chromogranin B are good as delineated neuroendocrine tumors, carcinoid, pancreatic, phreos, multiple endocrine neoplasia type 1 patients, and so on. So our both assay A and B are working quite well. The level of chromogranin B is significantly lower than chromogranin A, as you are aware of. This is a study we published a couple of years ago in patients with multiple endocrine neoplasia type 1, and I just want to point out that you can follow the development of the disease in this group of patients that develop different kinds of neuroendocrine tumors, pituitary, parathyroid, pancreatic tumors, adrenocortical tumors. And those with only biomarkers elevated in the beginning had rather low levels of chromogranin A. That was patients with, but as soon as they started to have tumors seen on X-ray or radiology, the levels rose considerably. So in this group of patients, you can follow over time the development of new lesions in the disease. You can also follow, if you have a good assay, the disease over time in your patient. And that was a patient that was subjected to radical surgery, and we followed her afterwards with during treatment with interferon. It was a trial that was ongoing in Scandinavia to use interferon adjuvantly in curable resected patients. And if you have a good assay, you can see the increase in chromogranin A also within the reference range if you follow that over time. It took 24 months to get positive radiology. So 2 years of rising chromogranin A until we could see it on CT scan. You also heard yesterday that we can correlate circulating levels of chromogranin A with survival, and this is a study from Holland, and high levels of chromogranin A is clearly indicated a worse prognosis. You also heard yesterday about that decreased kidney function is one of the pitfalls that give you falsely elevated levels of chromogranin A. Sometimes patients with type A gastritis, which is not an uncommon disease, at least in Scandinavian countries, and sometimes give you 3, 4, up to 5 times upper reference lane. And you also heard yesterday about the PPIs. I think you must be aware of that PPIs elevate chromogranin A without giving a tumor disease. I mentioned that we are using chromogranin B, and the reason is that chromogranin B is not sensitive to the kidney function. Rising serum creatinine is not giving higher levels of chromogranin B, whereas this is the case for chromogranin A. So we are quite happy to have both chromogranin A and chromogranin B in our hospital. I mentioned that we are working on new markers because I think we realize that we need more sensitive markers to be able to diagnose the tumor as soon as possible, and also recurrence after surgery. And I just want to point out three of the markers that seems quite promising. This is GRIA2, which is a marker that's not found in normal EC cells. It's just demonstrated in high levels in midgut carcinoid tumors. SERPINA10 is a circulating marker that is also found in midgut carcinoids. What we are now trying to see if it's correlated to the tumor mass and how early we can see it in the disease process. And also the olfactory receptor family 51, which is also a new marker, which is quite interesting also to develop further. These were first diagnosed by mRNA expression in the tumor, but we can also demonstrate that there are peptides that can be noticed both in the primary tumor and the metastases, so we can stain with specific antibodies. So that was what I would like to say about biomarkers. You want me to use the mouse?
Please.
Okay. Do my best. You saw this slide yesterday, so I don't have to explain it, but it's no doubt that it's quite sensitive. The PET scanning with the carbon-11 labeled peptides labeled isotopes, and gallium-68 and copper-64 are the most sensitive agents for detection of neuroendocrine tumors. And also my message that FDG PET is working mainly in high-grade tumors with high proliferation. And we discussed that yesterday about Octreoscan, MIBG scan, and PET scan. We have specific isotopes, carbon-11, 5-HTP, dopamine, fluorine-18, dopamine, gallium-68, octreotide, and also this insulin-producing tumor-specific tracer GLP-1. And this patient with a florid-Solling-Ellison syndrome that had a 5-millimeter tumor that was detected only by carbon-11 5-HTP PET and could be cured. And this study from Koopmans in Holland showing the difference in staging when you use different techniques. And again, I want to point out that, as you can see with this, in this you have only using CT scan and Octreoscan, you just see the primary tumor, nothing else. You get a completely different staging of the disease. But if you use our isotope 5-HTP, carbon-11 label 5-HTP, you got a completely different staging. This patient had multiple lymph node metastases and also bone metastases. So you can see the bone metastasis here, here. So depending on which method you are using, you get a completely different staging, and of course also that has implication for the treatment of this patient. If you just have the CT scan and Octreo scan, the surgeons might have said, maybe we do a Whipple's procedure and take out this tumor. But when you see this PET scanning, of course, is not so eager to make the surgery. And I mentioned that gallium-68 Octreotide might be the choice for most centers in the near future. I think there are also many studies now coming out from Europe indicating that this is a better method than Octreoscan, and you are not needing any cyclotron, and it's more sensitive than Octreoscan, as I mentioned. It's also a possibility to quantify somatostatin receptors. Another thing is that you can it's a one-stop procedure. You come to the hospital, you get the injection. 30 minutes later, you are doing the PET scan, and within 1 hour, you can leave the hospital instead of coming back 24 or sometimes even 48 hours for the next scanning with Octreoscan. So it's no doubt that in most centers, in 5 years' time, it will replace Octreoscan. And I said yesterday that there is a lot of possibility to label different enzymes, proteins, peptides in the body, and you can almost study whatever biological process in the body, everything from angiogenesis to proliferation to apoptosis to different signaling transduction pathway. It's only the time, money, and chemical skill that is necessary. I think molecular imaging has really the future. So now I will talk about the treatment landscape, and this landscape is really moving forward. And you have a lot of options today. These are the options that I can definitely provide my patient coming to me today. Good surgery. 60% of our patients are actually metastatic disease, and curative surgery is not possible, but our surgeons are quite keen on doing ablative treatment, cytoreductions, bypassings, and so on. Debulking procedures, radiofrequency ablation, embolization, chemoembolization, and radio embolization is also done at a lot of in our hospital. Irradiation, external irradiation, mostly for bone and brain metastases, and then we have the tumor-targeted treatment, radioactive treatment, yttrium-90-DOTA-TOC and lutetium-77-DOTA-TATE. And then we have the medical treatment, including biological treatment and cytotoxic treatment. The factors that are influencing the therapeutic decision at our department is the type of neuroendocrine tumor, TNM stage and grade and WHO classification, extent of liver involvement, functioning versus non-functioning tumor, and patient's performance status, and also, of course, availability of different therapeutic modalities. But it's quite important to realize that this is a multidisciplinary team, a tumor board that is taking the decision upon the treatment of the patients. We have such a tumor board every week because we see about 35, 40 patients a week coming to our center. And so every patient is at least once discussed in our tumor board. If you look at the evolution of medical treatment of neuroendocrine tumors, I just made this slide for fun, And we have the cytotoxic era. All patients, whatever type of neuroendocrine tumor they had in the late 1960s, early 1970s, and up to 1980-84, they received cytotoxic treatment, and it was mainly streptozotocin, 5-FU, and doxorubicin. And you can see the names of the people that was really pursuing this type of treatment. And then the era of biotherapy started and was born with somatostatin analog and alpha interferon, and that was in early 1980. And actually I got Octreotide in 1983 in Sweden, and I developed alpha interferon in 1980-81. And Larry Qualls, I know, got at the same time in US Octreotide at Mayo Clinic, and it was also around 84-85. And then targeted treatment is the key word for the next era in 2000. It started with PRRT, peptide receptor radiotherapy, mTOR inhibitors, VEGF inhibitors, tyrosine kinase inhibitors. But you must realize that really the first targeting treatment was somatostatin analogues, Octreotide. So, but it was not mentioned as a targeted treatment in the very beginning. And Erik Krenning in Rotterdam has been instrumental for development of PRRT and also Octreoscan. James Yao and Matthew Kulke in US have been doing a lot for mTOR and VEGF and tyrosine kinase inhibitors. This is Jacques Martel, the father of neuroendocrine tumors. He was giving a lecture at ASCO in 1987, and he was discussing the land of small tumors. And he has also been writing this paper on life history of the carcinoid tumor in the small intestine. And he was pursuing a lot of cytotoxic treatment. And the streptozotocin was the first drug he really pursued, together with some others. And the good thing with streptozotocin, it was that it was quite good in pancreatic neuroendocrine tumors. You could see significant tumor reductions. This is a patient we got almost 20 years back with a significant tumor mass in the liver. And after 6 months of treatment with streptozotocin, it has significant reduction, and the patient remained in a good clinical condition for another 3 years. However, if you look at the survival data, and remember this figure to my very end of my talk on treatment, this is midgut carcinoid patients with metastatic disease. You have a 5-year survival of about 30%. You have a median survival of about 2 years. So remember that, median survival of 2 years, and you have a 5-year survival of about 30%. And that is in midgut carcinoid tumors with liver metastases. If you summarize some of the important studies on cytotoxic treatment, in the early 1980s, the response rate was quite high, and also the median survival indicated by the studies. But if we look very carefully for the most recent data, and Kovarakis study a couple of years back using streptozotocin, doxorubicin, and 5-FU is indicating a 40% response rate, which is what we can expect today to see with this type of treatment, and a median survival of 40 months. If we then look at carcinoid tumors, classical metastatic midgut carcinoid, you see that the objective response is only 15 to 16%, and median survival rather short, 15 to 20 months, which is rather short compared to what you can obtain with biotherapy today. If we look then at poorly differentiated tumors, these high-grade tumors, cisplatinum and etoposide is still the working horse, and you can obtain some significant objective responses with rather long duration for this type of really malignant tumor. We started to use temozolomide a couple of years back. It was originally developed for glioblastomas, astrocytomas, and the reason for us to use it was a patient that came to us with brain metastases in a really bad condition. And I had just seen some studies coming out on brain tumors. I said, maybe why should we not test temozolomide, because it's a DTIC type of substance, and DTIC had been working years back in neuroendocrine tumors. And the patient got a complete disappearance of brain metastasis and also liver metastasis. So that was why we started the first study on temozolomide. And if you look at the study we published in Clinical Cancer Research in 2007, it was 36 patients. And if you look at the response rate all over, 14% is not that impressive. But we did a subgroup analysis. We looked at an enzyme called MGMT. And you heard yesterday from Dr. Esat that methylation of DNA is a very important feature in development of different malignancies, and this enzyme is hypermethylating DNA in neuroendocrine tumors. So if you have a low MGMT, you're better off. And if we just look at those patients with low MGMT, the response rate was 40%. So again, here you have a marker that can indicate that you respond to a certain type of cytotoxic treatment. Isakov published a combination of capecitabin and temozolomide, and Kulke also reported on a combination with bevacizumab, Avastin, with rather good responses. But if you look at Kulke's data, only pancreatic tumors responded, not the carcinoids. And if we go to our study again, if we look at those with MGMT positive or high, we have no responses, whereas those with negative or MGMT staining or low expression, 4 out of 5 tested responded. And what then happened was that Kulke looked into a large material of patients with pancreatic tumors and also midgut carcinoid tumors. And 50% of those with pancreatic tumors had low MGMT or should respond to temozolomide-based treatment, whereas 100% in his material of midgut carcinoid had high levels of MGMT and should be resistant to this type of treatment. It's not that easy now in the clinical practice. I have just seen a couple of midgut carcinoid patients with the low MGMT responding to temozolomide. So there are differences. So we are now routinely analyzing our specimens for expression of MGMT to see if the patient can be a candidate for treatment with temozolomide. This is the most recent study on the combination of temozolomide and capecitabin in pancreatic endocrine tumors as a first-line treatment. And as you can see, you have 67% partial remission with the RECIST criteria. Just to take this drug further, this was a patient coming to me from Hong Kong in a real bad condition. He needed an ambulance from the airport, and he had received cisplatinum and etoposide for a bronchial carcinoid with very high proliferation. Ki-67 was 85%. And if you look at the first part of the slide, that was his situation when he came in January 4, 2006. I started him on a new combination, Capecitabin plus Temozolomide plus Avastin or bevacizumab, based on some initial animal studies we had in the lab. And he responded quite dramatically. You can see already after 4 months he was completely free of tumor. And after another 2 years, I took out the cytotoxic part, Capecitabin and Temozolomide, and he's just now only on Avastin for 1 year, taking 10 milligram per kilo intravenous once a month. And you can see, I saw him in September 9, and he had completely, is still without any recurrence of the disease. So this is a combination I would suggest for really high-grade tumors, that you can use this combination. Biotherapy, I think, is one of my favorites. I think it's good to have this kind of treatment for slow-growing tumors, and you're not poisoning the body with cytotoxic agents. And Octreotide and Analogues are working in the same. We heard before from Dr. Odorisio, binding to receptor 2 and receptor 5. We have a new analog SOM230 or Pasireotide, which is now in clinical trials. The first trial is randomizing midgut carcinoid patients to either Octreotide LAR or SOM or Pasireotide LAR. And we are still recruiting patients for this study, so we have not a result, but it will be interesting to see if SOM is superior to Octreotide. SOM is binding to more receptors, receptor 1, 2, 3, and 5, but not 4. We usually call it a pan receptor analog, but as it's not quite fair because it's not seeing a receptor 4. If we look at the expression of somatostatin receptor and just took a material of pancreatic endocrine tumors, you can see that receptor 2 is most heavily expressed in our tumor patients, which is lucky for us using Octreotide. But as you can see also that using specific antibodies to the different subtypes of the somatostatin receptors, you have expression in both of receptor 1, 3, 4, and 5, and quite high of 4 and receptor 4, where we don't have an analog at the moment. So that is something that is interesting for the future to pursue if we can develop a type 4 receptor analog. You can expect about 64% symptomatic improvement, biochemical responses in 65%, and tumor reduction in about 5%, but stabilization of the disease in up to 50% of the patients using standard or slow-release formulations of Octreotide or Lanreotide. This is just a table summarizing studies in Europe on looking at the anti-tumor response, and you can see again about 5% objective responses, but 50% stabilization of the disease, which is a real good response in these studies in these patients. And sometimes you can see a very dramatic reduction of the tumor size. This is a patient with non-functioning pancreatic tumor responding quite well to standard Octreotide LAR with a reduction of both Chromogranin A and tumor size. This is a PROMID study. It was mentioned yesterday at least 2 times, and I just want to summarize it. It's the first randomized placebo-controlled study in classical midgut carcinoid, well-differentiated tumors, low proliferation capacity, less than 2%. It has also low tumor burden, less than 10% liver involvement. And the most important slide is this, showing an increased time to tumor progression and compared to placebo. Most recent compilation of the data is indicating even higher time to tumor progression, 16 months versus 6 months. And it's also important that he included both functioning and non-functioning tumor, and thereby a lot of different organizations worldwide have started to revise their guidelines. NCCN in US was the first to change the guidelines. So now Octreotide LAR is the first line treatment for both functioning and non-functioning tumors. And we are changing the guidelines in ENETS next month. And the Scandinavian group has changed the guidelines one month back. And I know that in Canada also that you have decided to change your guidelines. So Octreotide LAR could now be prescribed both to functioning and non-functioning tumors because we have the data on an anti-tumor effect. I have been always believing in an anti-tumor effect, and we have been using high-dose treatments, high-dose studies over the years. And so we have taken patients on proliferating tumors that has stopped growing during treatment with somatostatin analogues. So I have been a strong believer, so I'm not surprised about the outcome of this study. One problem in the study was that the number of patients with high tumor load, about 10%, was very few, and therefore we can't draw any conclusions from this data, because we need more patients to see if there is a difference between Octreotide LAR and placebo. It's also maybe a matter of dose. High dose treatment of patients with higher tumor load might be of benefit, but that has to be, of course, demonstrated in another study. But unfortunately, I don't think it's possible in Europe to make any further placebo-controlled study with Octreotide. I don't think the authorities will agree upon such a study. The anti-tumor effect is there, and it's inhibition of cell cycle, inhibition of growth factor effects, and pro-apoptotic effects. It's also inhibition of release of growth factor and trophic hormones, inhibition of cell angiogenesis. I think that is also something you should keep in mind, that they are also inhibitors of angiogenesis and modulation of the immune system. Interferon is not so widely used in Canada. I know that in some places it's an option. And I think the most important take-home message is that you should titrate the dose individually in each patient so they can tolerate it for long-term use. We try to reduce the leukocyte count down to 3, and we are using more and more pegylated alpha interferon, 75 to 150 micrograms per week. And if we summarize studies done on interferon, it's quite clear that you have a symptomatic response in 62% of the patients, biochemical response in 50%, and tumor regression in 10%, and again stabilization in 65% of the patients. How can we use interferon and Octreotide in combination? We are using it quite often, because when you start to see a resistance to Octreotide, we add alpha interferon, and usually they work quite good together. Another thing we are using it for is to upgrade the number of receptors for somatostatin type 2 receptor. And this is a patient that came to us for treatment with the PRRT, lutetium. But as indicated here, the first Octreoscan, the uptake was not that impressive, so we decided to give her 3 months treatment with alpha interferon, and when she came back, you see this high uptake, significantly higher, and she was able to get treatment with PRRT. Another thing which is quite interesting, and I think that is a study I really want to do in the future, Pasireotide or SOM230, this new somatostatin analogue, has been used in another study, early study in patients with resistance to octreotide. And this patient had a quite good clinical outcome. She had less diarrhea and flushing, but the tumor grew constantly. So if you look at the tumor continued to grow even though the patient was feeling better in terms of clinical symptoms, and also the chromogranin A levels rise. So after a year we took her out of study and added alpha interferon, and you can see a significant effect in terms of dropping chromogranin A, and also a significant reduction of the metastasis, more than 70%, already within 3 months treatment. And we have seen a similar results in another 2 patients coming out of this study as well. And I think that is something we had to look more carefully into, if this combination might be something of real value for the patients. mTOR inhibitors was mentioned yesterday. mTOR is an important signaling way in the tumor. It's regulate cell growth, proliferation, angiogenesis, and also the energy supply in the cell. And we know that the mTOR pathway is activated in our tumors, and therefore RAD001, or everolimus, or Afinitor as it's registered now, has been used in 3 different trials conducted by Novartis. And we have also combined in one study with Octreotide, and Octreotide LAR is blocking some other signaling transduction pathways, whereas everolimus is concentrating on the mTOR pathway. And by combining, we hope that we should see a more anti-tumor effect. And that is also maybe what is true. This RADIANT-1 trial, which is finished and closed, if you look at clinical benefit, partial remission plus stabilization of the disease, it was 76% in everolimus alone. And if you combine everolimus with Octreotide, LAR is 82%. And if you look at the progression-free survival, which is now reviewed, we will publish this data in the near future. It's a significant advantage to use the combination compared to everolimus alone. And so we have also closed the RADIANT-2 and RADIANT-3 study. RADIANT-2 was in classical midgut carcinoids, and RADIANT-3 was done in progressive pancreatic endocrine tumors based on the data from RADIANT-1. And all these studies are recruited well and are closed, but we are still waiting for the results of the analysis. As said previously, that these neuroendocrine tumors are sometimes quite unique, and they express a lot of angiogenic factors, and these are really angiogenic tumors. And just to give you an example of this, this is CT scan after intravenous contrast enhancement. And you can see that the contrast is concentrated in the tumors, indicating high blood supply. And a lot of substances have been attempted to block the angiogenesis. I think all the NIBs and MUBs that are available for other cancer types have been evaluated in small studies in neuroendocrine tumors. And again, the objective response rate is about 10 to 20%, and PFS about 11 to 16 months. So we have to learn more. We have to be more intelligent. I sometimes say that we have more drugs than patients. So we had to look for how we should use it. The new SUTENT study you heard yesterday from Dr. Odorisio is quite interesting, that It has not come out in the publication yet, but it's not finally evaluated. But comparing sunitinib orally 37.5 milligram with placebo is indicating a significantly longer PFS, time to progression. So it looks very interesting, and that was done in pancreatic tumors again. I mentioned that in Europe, also in Sweden, we have the possibility to give radioactive treatment, and yttrium-90 has been available for long periods of time at different centers, Paganelli in Milan, at the Basel group, and also Eric Krenning's group in Rotterdam. But we are more and more using lutetium-177, and the reason for using lutetium octreottate is that octreotide is binding with higher affinity for the somatostatin receptor. It's less toxic than yttrium. It's less negative effect on bone marrow and kidney. And we can present objective response in about 30% of the patient, but again, a stabilization of the disease in 50%. And what we really are doing is we set back the course of the disease 4 or 5 years in most patients. So if you are well ahead in your course of your disease, we can set it back by giving this type of treatment. And of course, take away a lot of negative clinical symptoms. It's also rather well tolerated. Patients previously receiving cytotoxic treatment can get some problems with the bone marrow with low platelets count. So, ending up with some final conclusions. We have a therapeutic algorithm that we are following quite carefully in our unit, and it's accepted by the whole tumor board. In metastatic neuroendocrine tumors, surgery is always discussed, different debulking procedures, including embolization, chemoembolization, radioembolization. If you have a patient belonging to the WHO1, which means that they have a low Ki67, again, you can see that I'm using Ki67 quite a lot in my clinical work. If you have less than 3%, biotherapy is first-line treatment. No option for cytotoxic treatment. If we have a WHO3 tumor with the Ki67 about 20-25%, chemotherapy is the first option, and no further discussions there. But then we have the problem. We have the patients in the gray zone, those WHO 1 to 2 with Ki67 somewhere between 3 and 20%. What should we do with them? And there you have several options. You can, of course, use cytotoxic treatment, streptozotocin, 5-FU, doxorubicin. You can use streptozotocin and RAD-001, temozolomide and capecitabin in some of these tumors as well. And, of course, you can also use biotherapy. So sometimes we start with biotherapy, and as soon as you see a progression in this group, we go for cytotoxic treatment. Or sometimes we start with chemotherapy, and when you have got a significant anti-tumor response, we switch over to somatostatin or alpha interferon in the long run. It's also important to point out that somatostatin is used in all three groups to control clinical symptoms. As second or third line treatment, we use targeted radioactive treatment, and of course we have experimental protocols. Just to give you an idea of what we can obtain in the center of expertise taking care of neuroendocrine tumors, I just want to show you this survival curve. You saw it in another format yesterday morning. And the yellow line is survival in our center for patients with metastatic carcinoid tumors. And the median survival is 115 months and a 5-year survival of 77%. Remember the figure from the early 1980s I showed you in the beginning. The 5-year survival rate was 30%, and the median survival of about 2 years. What is actually happening in US? And I'm taking just from the SEER database. I'm not going to dedicated centers, because the dedicated centers, as you also saw yesterday, have similar response rates as we have. But what the general American patient can get when he goes to a doctor that are maybe seeing just 2 or 3 patients a year. And if you look at the data from before the introduction of somatostatin analogue in US, the median survival were only 17 months. And these patients received cytotoxic treatment. That was the same that I showed you in the very beginning from Chuck Mertel's paper. And then when octreotide came into general use in US, and the next evaluation increased the median survival to 37 months. That is the blue line. But what is really disappointing me is that the last compilation of data in the James Yao study is not showing any further improvement of the median survival in the general American population. And my only explanation is that these patients with neuroendocrine tumors had to be centralized to a dedicated center taking care of these type of tumors, because they are rather complicated diseases. And by that they also get an improved quality of life and also improved survival. For the future, I think we had to explore and classify our patients better. I don't know if the WHO and TNM classification will be the end results, but it's a working horse just now. Personalized treatment is actually what we are trying at our center, using a lot of biological and molecular markers. And we are also working on completely new therapeutic modalities. Actually, we are just now developing oncolytic viruses, where we put the chromogranin A promoter into the adenovirus, thereby direct the virus into the metastases, and it's only activated in cells producing chromogranin A. We are using nanoparticles, lipids, and carbon particles loaded with different substances, covered with octreotide, and thereby making a magic bullet that goes to the tumor, binds to the type 2 receptor, and is internalized into the tumor. So we had to explore the uniqueness of these neuroendocrine tumors, not only taking substances from the shelf of what the medical companies are offering for other types of neuroendocrine or other types of malignancies. I come back with a cartoon about the multidisciplinary team. And these are well-known things for you. We need gastroenterologists, endocrinologists, radiologists, nuclear medicine persons, surgeons, pathologists, oncologists, and a tumor board and transplant team. But as important is to have access to a support group. And actually, the first patient organization in Europe came from our hospital called CARPA. And it was developed by 2 foreign patients, one coming from Iceland and one from Switzerland. And they organized this in Sweden. And now all the Scandinavian countries is joining this patient support group. And I think it's good to have a close connection with them to discuss how we should move this area forward. And I think the multidisciplinary team is very important. You must have it there. You must have it all the time. So thank you for your attention.